And we do things like, in a normal year, we do 4 in-person retreats every year where we bring together about 20 to 30 young people, bring you all in for a weekend where you guys can get to know each other. You can hear from experts, engage in workshops, creative arts therapies, and really just have an opportunity to connect and be in a room where you don't have to explain what HD is, which for a lot of people is kind of revolutionary. But in this sort of virtual world, what we're doing is we are having a lot of little mini series, mini discussions. So we've put together a really awesome slate of mini series that are happening on noon Eastern on Saturday, well, mornings, I guess. Check out the NY website to see, to register and to see when all of our mini series are. But we're going to be talking about things like, what do you do if HD isn't the only diagnosis in your family? I think it's easy for us to focus on HD because it is such a high needs disease, but what if you've also got, a sibling who is autistic, or your unimpacted parent has cancer? What does that mean? What are those kinds of stresses that you go through? We're going to be talking about preparing for genetic testing, what it means to test positive, which can be a pretty big, pretty big impact on your life. And similarly, what it means to test negative. That's also really impactful for folks. We're going to be talking about building families. So, the decisions that you can make, the choices that you have when you want to build a family and you have HD in your life, and so much more. So check out our website, www.hdsa.org/NYA. Register for one of our mini series. We look forward to seeing you, look forward to meeting you. And you can register for as many as you want. For like, all of these are interesting, you can register for all of them. And hopefully that's what you'll think. A program where if you are a young person and you want to talk to someone else who's impacted by HD, who knows your experience or who can empathize with what you're going through, we do have some peers who have been specially trained, who we can link you up with as a like a peer-to-peer connection. Again, if you are interested, you can always reach out to me, jsimpson@hdsa.org. We also have youth social workers. So we have created a youth social worker program that we are year on year expanding. And part of that is we have our chapter social workers who are, trained in HD, who's been in this world for a long time. We have given them additional hours and additional training to work with young people, whether it's, helping you have tough discussions with your family, tough discussions with a partner, working with school guidance counselors or teachers to help train them on what HD is, to do informational work with them. If you need someone to just have a discussion with, that's not a parent, that's not someone who is, personally invested in what's going on in your life and has, that sort of, and isn't, I don't know about you guys, but aphasia is a real problem.
I'm here to help.
Not biased. Who's not biased? Oh my goodness. There we go. I got it. Word loss is so real. Who's not biased and can be a real person to listen to you, to listen to what's going on in your life and help provide you some guidance and just be a good ear. They're available for that as well. So again, all of this is up on our website. You can contact any of the youth social workers. They're all available to chat. And that's a great resource for you. Or if you're a parent and you're thinking, I don't know how to talk to my kid about this. I don't know what's going on. I'm a little bit nervous. Can I talk to someone who maybe knows about young people? You can always reach out to our youth social workers as well. We also have partnerships with other youth organizations. So you guys might know HDYO. So we work really closely with HDYO and our Canadian partners up at in YPAD, which is young people affected by Huntington's disease, which is sort of the Huntington Society of Canada's youth group, to make sure that the services that we're providing, the programs that we're creating are up to the absolute best standard and best practices for young people impacted by Huntington's disease. So check us out. Thank you guys so much for having me this morning. I don't want to monopolize any more time. I know you've got a packed schedule. It's always a pleasure to chat with folks in New Jersey, and thank you guys for having me.
Thank you, Jennifer.
Very nice.
Thank you, Jennifer, very much for joining us. I really do appreciate your input and everything, and really interesting to hear about the youth social workers that are out there. I think that's really a wonderful resource that we'll all be utilizing. So thank you.
Absolutely.
Enjoy your extra hour.
Yeah.
Although we were all up early.
Excellent. All right. Thank you. So next up we have Lynn Cirillo, and she's a speech and language therapist, and she's going to be sharing with us a little bit about what she does. I'm going to share my screen, and then Lynn, if you can just tell me when you want me to advance the slide, I can do that.
Oh, okay, that's great. I have it on paper here too, but that would probably be more natural then,
Okay.
if you have it up there.
All right, so I'm gonna give it a try.
Okay.
Okay.
There it is. Is she still on?
I don't know.
Oh, there you are. Okay.
Okay.
Oh, I see you. Okay, thank you.
Yep.
Okay, so I'm a speech therapist at JFK Medical Center in Edison. This is my 33rd year there. But I'm also been the sole speech therapist on the Huntington's unit in Plainfield, New Jersey at Hartwick since it opened. So I have a lot of experience with HD. Also at the last family conference last year, or 2 years ago, I did explain that I also have Huntington's in my family, which was a big surprise. It was never discussed. It was on the other side of the family when I was dating my husband for 16 years. When we got married, we had children, and I didn't find out till after my second son was born that there was Huntington's in the family. So since I've spoken with you folks last time, my sons decided to get tested. One is positive, one is negative. And their father, my ex-husband, is advancing. His brother is advancing. So there's been quite a bit of change in terms of how it affects our family. So I was appreciative of what the first speaker was talking about. I think that it is very different when you have two and one tests positive and one tests negative. The person that tests negative feels a little guilty, a little weird. But I'm happy to say that my younger son, who tested positive, is very focused on the care of his father and making sure that his quality of life is good. So he's feeling very encouraged by the fact that there are things in the works, and by the time that he may become symptomatic, there are things out there, and that keeps him hopeful, and he's online all the time and investigating all the time. So I feel that for the moment, it's okay because their focus is on their father. But I usually bring this up at the beginning of the HD family conferences that I've spoken to, because way too often, I see it in the hospital all the time, doctors will say to family members, or therapists will say, oh, I know how you feel. I understand how you feel. And the person's dying of cancer. Of course, they have no idea how they feel. And many of these people have never lost anyone to that. So as much as people try to be empathetic, I am a person that comes from a place where I'm on both sides of the fence. I work with all levels of HD in my job, but then also have it in the family. So sometimes I feel it's helpful for listeners to know that when I say, I get it, I get it. So moving ahead, a little bit of history about Huntington's disease. I'm sorry, you could slide. Again, forgive me, virtual is not my forte. So a long time ago, aspiration pneumonia was actually the #1 cause of death with Huntington's disease. And that's because swallowing is affected in most cases at some point of the disease process. And back then, if people were coughing or choking or getting pneumonia over and over again, people just assumed that it had to do with the disease and not what was physically happening. But over time, it was finally discovered that these people were swallowing down the wrong pipe and developing what's called an aspiration pneumonia, which is different from a regular pneumonia. The more that you have that consistency continue to go down the wrong pipe, it collects in the lung, usually the lower lobes, and you can't fix it with antibiotics until somebody changes the diet to something more safe. Which brings me then to the next comment, which is freedom of choice for our folks. So usually with HD, little by little, they lose their freedom of choice to go places, do things, drive. And that's very frustrating. And what I find in my job is that one of the last things that is their own freedom to choose is what they eat and what their diet is. Now, a lot of times you can reason and explain, and I can say that outside of the group of HD working on swallowing in the hospital with all walks of life, it's not much different when you tell someone they have to be on a puree diet and nectar thick liquid. People aren't happy with that. No one says, great, I can't wait. It's a crappy diet, but it's what they're safe with at the moment. And either we determine that from a bedside evaluation, which I'll go over in a minute, or we discover that with a modified barium swallow, which is an X-ray test of the swallow. And the food is mixed with barium powder so we can see where it goes, how it goes, sometimes why it goes down the wrong pipe. So on the unit, we try to be very flexible. There are people eating on the unit that probably would not be eating if they were at the hospital or a regular nursing home who doesn't know how to deal with Huntington's. So there's a lot of freedom of choice on the unit for as much as we can do without them getting sick repeatedly. So my rules are, if they're not coughing through the entire meal, which makes it not enjoyable, if they're not developing, if they get one pneumonia, that's not terrible. But if they start to get a pattern of pneumonia, then we know that it's a much more serious problem that can't be fixed that easily with a diet change. But we keep it open. Sometimes I've gotten more creative with people not allowed to have thin liquids, but they can tolerate ice chips or Italian ice because it slowly melts. It's not like a full teaspoon of water. It slowly melts and their swallowing can handle that. And this way they still get a little bit of freedom to have a version of thin liquids. So just freedom to choose is very important to all of us that work on the unit and everybody in their life. So why should it be different for somebody with HD? So also when things come up and these folks get sick at home, a long time ago, I was given a good piece of advice, which is make sure you rule everything else out because it's not always the Huntington's. And I think people tend to worry, especially more newly diagnosed people, like, oh my God, I can't remember this. It must be the Huntington's. I just turned 59 in August, and Karen will attest to the fact that if she tells me something in the morning, I'm asking her the same question in the afternoon. And I'm a person that doesn't have any outlying problem. I just have 59-year-old brain. So we also take that into consideration too, the age of the patient, what's driving them to be upset, what's the problem. When we look at all other possibilities before just assuming it's because they have a neurological disorder. Go ahead and switch. Thank you. Oh, wow. Okay, so I'm gonna have to now put my glasses on. Okay, there we go. All right, so a swallowing evaluation for everybody is the same. We see somebody bedside. We start with very easy food first, usually applesauce or pudding, something puree. If they do okay with that, we start from back to front. So a thicker liquid, then a little thinner, then a little thinner. So it's honey thick liquid, nectar thick liquid, and regular liquids. If they're okay with all of that, then what's separate is the solids. So one thing that people don't realize is sometimes people can be terrible with food, but still okay with liquids, and vice versa. Sometimes they can eat sandwiches, but they can't drink water or juice. They have to have a thickened liquid. Liquids are the more commonly aspirated item. When you look at a person's trachea, there's branches that come off into the two lungs. The right lower lobe is higher up. And so if someone's going to aspirate into their lungs, it follows the path of least resistance and just goes into whatever is the first opening that it finds, which is the opening to the right lower lobe. So aspiration pneumonia is most commonly noted in the right lower lobe, but it can also be in the left lower lobe. Sometimes it depends on how the person sleeps or lays down when they're resting or positioned. But usually anything in the lower lobes is not good. That can be assumed that that's a swallowing issue. We also have silent aspiration, which is a tricky thing to deal with as well, because when you're doing a bedside evaluation, there's no way to see or hear that someone is aspirating because they have desensitized in their upper airways. So what would make you and I hack up a lung, a little inhaling our saliva, inhaling water, I'm sure everyone's done it. It takes a while to recover from that. You keep coughing, coughing, coughing just to try to get it out of your airway. A lot of these folks don't have that sensation in the upper airway. So that means the liquid travels further down to a place that once you finally sense it and start coughing, it's too late and you can't really hack it out. So when somebody swallows, and we do this modified barium swallow, we call residual airway penetration when it's actually sitting in the person's airway and they don't feel it and they can't cough it out. So that's when it's silent. Residual is when it's sitting there, but they do feel it and they start to cough like you and I would. The modified is what really tells the story, because the bedside evaluation is kind of educated guesswork. There are a lot of little things that we look for in terms of signs and symptoms of aspiration, and some of those things are very obvious. Coughing, throat clearing, heavy breathing. Sometimes if people have a little pulse oximeter at home, sometimes your pulse ox will go down. A normal pulse ox is 98 to 100%. Sometimes in a moment of aspiration, that number will go all the way down to 90 or below 80 because the person can't catch their breath from the coughing. But the modified barium swallow confirms what we suspect. Or sometimes there are people we call super coughers, and they just cough a lot and they don't actually have airway penetration when we finally take them to X-ray. The FEES is a fiber optic endoscopic evaluation of swallowing. That a lot of HD folks don't tolerate, and it's not always safe because it's a scope that advances down and looks from the top down because the camera's at the bottom. If people have chorea and it's significant enough, we can't use the FEES because it would be moving around too much. But for some people that have the disease but not too much chorea, this is a way to evaluate swallowing that doesn't have to drag them to a hospital for X-ray. There are different speech people that come from place to place, and they'll do a FEES in the facility. Okay, go ahead. Thank you. So once the evaluation is done, there's a lot of different recommendations that we make. Obviously, the first being food and liquid changes. Sometimes it's positioning. So Karen will attest to the fact that in my 30 years of being at Cedarbrook and my 33 years of being at the hospital, I could just make a recording of myself saying, please sit that person up while you're feeding them. Please sit that person up while you're feeding them. It sounds, I'm sure, to everybody listening like that's ridiculous. That's common sense. Well, that is what some staff members lack. I've seen family members feeding a patient laying down. It doesn't lend itself to the swallowing being safe. Now, there are some people that are very difficult to position, and there you have to get a little creative with pillows, pulling the person forward, putting pillows behind them. We have some of those Careform chairs. I know they do at leisure also. They're very nice for the patient in terms of sitting and being comfortable, but I hate the patients being fed in those chairs because literally the bottom of the chair sucks them up and they're kind of like a V and their head is not in a great position. So I've showed the nurses how sometimes you can pull the person forward and put a pillow behind them, and then that at least brings them more upright for the feeding process. Sometimes the best place for feeding a patient is in their bed, and this has to be evaluated case by case, because if they can't be positioned well in a chair, the electronics of the bed sitting them upright or as close to upright as possible is where it's safer. Now, I know some people are like, oh my God, feeding in the bed is the worst idea, but see, we just play around with these things. We get creative. We see what's the best position that we can get the patient in. And so that's why sometimes it's the bed. The safe feeding technique, again, this is something I should put on a recording and just hit it when I see someone not feeding someone carefully. I've had patients themselves, non-HD and HD, tell me when I say, how are you doing? Is this going well? And I'll say, the people that feed you, how are they doing? And they flat out say, they feed me too much. They feed me too fast. They put too much food in my mouth. And so then I have to sort of re-in-service people and say, remember, these folks have a delayed swallow. You think they've swallowed, but they haven't swallowed yet. So now you're putting double the amount in their mouth and they're having to handle that. So safe feeding technique, includes good positioning, slow rate of presentation, alternating liquids with solids. Even if someone's on a pudding thick liquid, a pudding thick cranberry juice of 4 ounces is still liquid. And so if you have someone that you think is gonna sort of die out halfway through the meal, if you give all the food first and save the liquids for last, which some people do, and then they get too fatigued, then they're gonna have gotten no liquid for the meal. So I encourage them to alternate so that that person gets at least 4 ounces of their liquid intermingled with the beginning of the meal to make sure they get that liquid. Also, safe feeding technique is knowing your patient, looking at your patient. If the patient does something like this, hold on, stop feeding. Some people just think it's a random movement and aren't really paying attention to the fact that these folks that they're feeding understand everything that's going on. So there's a lot of continuous education, and I'm happy to do it because I just want it to be consistent for the patients. But it is something that I have to review very frequently, and this includes non-HD families. So that is a very, very important part of feeding. Go ahead. So here is what we just talked about. I call it is that it's not rocket science. You know, sometimes Karen is over complimentary. She's like, you have so much information to offer. You're giving people information they don't know. And my slide shows you how I feel about the information that I'm giving you. Feed the person upright. Don't feed people lying down. Wait for them to finish before you give them more. Give small bites, small sips. To me, it sounds like just common sense, what we would just be discussing at home at a family dinner, like, oh, this is how we eat. But it's not something that happens without intervention. If a person is coughing or choking, I have seen people say, oh, let's give them some water. That's the absolute worst thing to happen. If somebody is coughing or choking, the best strategy is to encourage them to cough and then swallow. Cough and then swallow. Don't introduce anything new into their mouth, not a liquid to drink, not a food to push it down. They've already got food in there. So they need to cough it out of their upper airway and then swallow it down the proper airway. I mean, cough it out of their airway and swallow it so it goes down into the esophagus. And the person can be very red in the face and fatigued from this process. So you shouldn't start feeding immediately after this, over this event. They need some time to recuperate, get their oxygen saturation back up, and have a chance to begin again once their whole system is calmed down. Yes, this makes the process longer. It's not always efficient for people that are working and have time constraints, but it's the safest way for these folks not to aspirate. Go ahead. So what happens when my people don't want to follow my recommendations? Sometimes we'll do a family meeting to try to educate everybody and explain everything that I just explained, to see if that helps the person understand better why it's a risk, why they can't drink water anymore. We discussed the quality of life versus the aspiration risk. And again, sometimes we'll do something alternate, like ice chips or ice that melts slowly. It kind of is a negotiation about the thin liquids, which is usually the biggest issue. Try to come to that kind of compromise, encourage the diet changes whenever possible. And we had a young guy who, for the longest time, refused to be on a puree diet, which really would have been the best for him. But we worked with him. First, he was on a soft chop diet, and we just fed him slowly. And I can tell you that there were a lot of nurses that were afraid to feed him because he had choking incidents. But his mom was also very supportive of him being allowed to have whatever he wanted there. So we all just worked very carefully. And then I would re-educate him again and say, can we move to fine chopped? Because you just had this horrific choking incident with a piece of food. And it was scary, wasn't it? And he said, yes, it was. And I said, they're not going to enjoy your meal if this is what keeps happening. So why not at least try the fine chopped, which we negotiated. His mom helped talk to him about it. And then he was on fine chopped also for a long time. And then finally he did agree to puree because he was just getting too fatigued. He was exhausted halfway through the meal. So at least with the puree food, he was going to get the calories in that he needed, even though it's not a desirable consistency of food, but he still tolerates thin liquids. So as long as he can drink water and have his shakes, he's happy right now at that point. So it was a long overtime, constant going back and forth, negotiating, trying to see what's the best. Some facilities have a waiver. It really does nothing except document that the people have been educated. but we don't change the diet in the nursing home or the rehab. We keep the diet the same of what we're giving. And then sometimes the family members, they will give the food, whatever consistency they want. And there's people around to kind of supervise, but it's not a diet that we can change at the nursing home. And then sometimes people have been kind of clever and included their wishes about their diet in their advance directive, where it specifically says, now that we had one case of that, and that was very difficult because he wanted regular food all the time. And he was having choking incidents on pizza and even pasta because of how slippery it is. It just slides down the wrong area and then gets stuck and the person starts coughing. But he did eventually advance to a level that he had to be on an altered diet, and his sister agreed at that time. But it was a real struggle for a while. The staff were very concerned and nervous. What if he chokes? What can I do? And we all just said, it's going to be part of the care plan and we're just going to try our best. So what really my point of this slide is that it's very helpful when family is supportive and we work together for compromising about the diet, because again, the quality of life is the most important thing. Okay. So here, this slide pretty much explains what I just explained. Go ahead. So when the person has a deterioration of swallowing, okay, which sometimes now goes to a sadder topic of end-of-life decision-making. We try to get these folks to talk about their advance directive when they're lucid, they're cognitively intact, and they can make a better decision about what they think they would want going forward down the line. And advance directives are asked for every person that enters the hospital. So this is the non-HD population as well. Everyone in this chat should have an advance directive saying what they want, and actually fill out a post, which is a form that can go with you wherever you are, so that if something happens in the ambulance, they won't do something that you don't want them to do. So feeding tube, would the person ever want to have long-term nutrition? The person sometimes says, forget about your advice. I want to eat whatever I want and take my chances. Those are people that usually are at home and we can't monitor what they're doing anyway. A person agrees to the most conservative diet, even though it's felt that aspiration is occurring. So the puree, pudding, thick diet is our most conservative recommendation. And that sometimes is a problem because they're still aspirating that. And then considering palliative care or hospice consult. In many cases, having hospice on board is helpful. It doesn't mean a person is going to die tomorrow. A person can be on hospice for 6 months before they would take them off. But it's helpful for people in the home and even people in the facilities. You get an aide that comes in 5 days a week for 2 hours a day. It's very helpful. You usually can pick the time of day you want that person to come in. So either for morning care that's becoming difficult for you at home, or afternoon care, like a bedtime before going to bed, they bathe and get the person dressed and can feed them a meal. So sometimes those consults are scary to people. They hear the word hospice and they think something's going to happen in a week. Sometimes that's the case if someone's very severe, but most of the time it's not going to be imminent. But it's a good thing to put in place if you already know that you don't want any long-term nutrition or care. Okay, go ahead. So allowable area penetration and aspiration. For me, my question is how much coughing or throat clearing is too much? So it depends on, as I said before, during a meal. If someone coughs a little bit here and there, it's what I call on the unit allowable coughing or allowable throat clearing. Everybody knows that people are going to do it a little bit with HD. In a regular facility, if people, like when I do a swallowing eval at the hospital on anybody, young or old, if they cough, if they throat clear, if they sound all gurgly and wet, like they can't manage their own saliva, these are people that are made nothing by mouth, or they're put on a very conservative diet and an NG tube is put in so they can get their medicine. We don't do that here. We try to do different things, as I said before, positioning, everything else, diet. If the person has to be suctioned every time you're giving them food, That's not good. That person shouldn't be eating, because then their quality of life is affected also. How enjoyable could that be if you drink water and then right after you're so gurgly and you can't manage it that you need to be suctioned every time? There's a rare person who says, I'll take the suction, I want my water. But most people realize that that would be very, very uncomfortable. And then, like I said before, with the example of the young man, it depends on how many choking incidents. There's only so many times you can risk someone dying from a choking incident. So usually we get back in there and try to negotiate. Go ahead. And then you'll also find what's the easiest fix for everybody to implement. We don't want to find something that's just for a family member to do. We want to try to find something that everybody else can. Now, this is communication. It depends on what I find, and I say this every time I present to a Huntington's group. We very often it's mistaken that people with Huntington's don't understand what's being said to them. That is like 99% of the time not true. A lot of times their receptive skills are fully intact, but they have a lot of difficulty explaining what they want. Or people see the chorea and it scares them and they think it's someone who won't understand what they're saying. So when I do education outside of the HD community, I make sure that folks at the hospital know that when these guys come over because they're sick, to make sure they're speaking to them, knowing that they understand, and not talk in front of them, not talk at the foot of the bed. Don't assume they don't understand what's being said, because we know they do. Alternate communication devices are very expensive. And what happens is these folks are changing on a dime. You do have some folks that just kind of slowly decline. And then we have others that are okay on a plateau for a while, and then boom, they drop down and it's a significant decline. And then they're on a plateau again, and then boom, they drop down again. So alternate communication devices are not out of the question, but because Medicaid is so strict about approval, you have to really show that the person can use it. Even with chorea, it's hard to access the buttons. Even with a key guard, there's so many things out there. There's iPads that people could do on their own. But as we all know, an iPad is very sensitive, touch sensitive. So just a slide the wrong way with a finger can, get rid of the picture. I mean, even with my own smartphone, half the time I say, oh, I'm going to take a picture of you. And then I hit some other button and who knows what's on the screen at that point. And the people are like, did you take the picture or not? So these things are great to use, but we have to make sure that it would be easy for them to use as well. For quicker, easier fix, also, if their vision is okay, some folks with HD have visual issues, but if their vision is okay, we'll do like an emergency word list. So a piece of paper that shows 6 or 8 words that they frequently need or use: pain, hungry, thirsty, position, TV, things like that. And then people can ask them yes, no questions, and they can nod yes or no, like, oh, you want your TV on? Yes. Or, oh, you want your TV on? No. So these word lists can lead to then questioning that's easier for them to respond to. But we always tell all the caregivers that you really need to always anticipate the needs of your person with HD. And again, this goes to people without HD, people with Parkinson's, people who have so many other TBI, traumatic brain injury, stroke. Lots of these folks can't communicate, but they can understand if they don't have receptive aphasia. So we have to try to always anticipate, well, we get to know our person. What do we think they need at 9 o'clock in the morning? They either want breakfast, they either want to be cleaned up. Some of these people want to be, repositioned. So these are things that we have to learn our patients and get to know what their needs are, so that as their communication ability declines, they have a way to let us know what they need. Go ahead. So dysarthria and short-term memory deficits are very prevalent in this population. What are some of the things that can be done? So dysarthria is muscle weakness of the oral musculature due to the neurological deficit. What that causes is very slurred speech. There's a different level of that slurred speech for whoever is involved. So first, we ask the person to speak slower, over-exaggerate their sounds, speak louder, and speak one word at a time. These 4 things, believe it or not, make such a difference with some of the folks I have on the unit that are young people whose dysarthria is so severe. Most of the staff can't understand what they're saying. We have one young lady in particular, and especially when she gets angry. Now, when she gets angry, curse words come out pretty clear. So I find that with a lot of people, if it's motivating enough and they're that angry, all of a sudden it pops out and it's clear as day. She's someone that will use a word list sometimes, unless she's upset. I have an alphabet board for her because she can spell, but when she's upset, sometimes that breaks down and she can't spell accurately past. But if they can even get the first 2 letters, it helps us guess what it is she's trying to talk about. It's most difficult when they're out of context. So out of context means you ask someone, how are you? And then they say a whole bunch of words, and you know it's not the word good, it's not the word bad. And now, because it's an open-ended question, it could be anything and you don't know. So closed context communication is much better because you know the possible answers that it could be. You know, how old are you? What are your children's names when you want to try to work on their speech? Count to 10, say the alphabet. What's my name? What kind of therapist am I? And these are answers that I know she knows. So we can work on her speech with doing that. Also with single word response, single word sentence completion. What do people drive? What do people use to brush their teeth? Again, this is closed context because we all know the answers to those questions. So those 4 things and knowing context on that first level are the most important. And when we get some of these people to speak just a little slower and just a little louder, we can actually get it. Teach a person the pacing technique. So pacing is when we have someone that talks way too fast. So you try to show them either maybe tapping their finger, this is what I want. And so you're tapping for every word, not every syllable, that's too confusing. But if you're tapping for every word and you're tapping with them and you're showing them to do this, can you guys see me? So sometimes it's tapping on your leg, tapping on your fingers, tapping like this, whatever is easiest for the person to do. Ask the person to spell the word first. Believe it or not, sometimes they can't get this word out, but they can give you the first 3 or 4 letters and you can guess what it was they were trying to say. And it's easier to make a single letter intelligible than a whole word. And then if they're able to use gestures, pictures, like we have one young lady who carries around pictures of her children all the time. So 9 times out of 10, if she's initiating something, it's about these pictures that she's holding. And it's of her children. So then you can engage a little bit in a conversation of closed context because it's about the pictures that she's carrying around. But those are just some tips for communication. Go ahead. So the short-term memory loss, these are some suggestions for at home. We also have done that where in our unit, label the drawers and closets so that everyone knows where their personal items are, clothing, radio, anything that they would have in their room. Review their important information every day that you see them. Who's coming to visit that day? I do orientation review with my patients for every speech session, and I encourage the nurses and the CNAs when they're with them and cleaning them and changing them that they also review. Today is Tuesday. It's 2020. This is Hartwick at Cedarbrook. It's fall. So you review these things, and then sometimes you can ask them these questions back and they remember it. Sometimes you can ask them these questions back and they don't remember what you just said. So that's why the daily review for things like orientation are important. It keeps the person in the moment instead of 1974, which sometimes that's when people tell me it is. Sometimes I wish it was 1974. I was a lot skinnier. Review temporal spatial orientation, got that. Use a big wall calendar and fill in the boxes with important items. Doctor's appointments, if it's a person that's higher level, and it can be large enough boxes, they can be filling it in themselves, because a lot of people that don't have chorea can still write pretty legibly. So then that's something they can feel they're doing independently on their own. I have a doctor's visit on the 14th and they can fill it in the box. Go ahead. Respectful communication. This is something that I do provide a lot of education as well. Don't talk about the person with them when you're in their presence as if they're not there. If they can comprehend what you're talking about and it's appropriate, they need to be involved in the conversation. There's too many times where people are talking to each other like, well, she did this and she didn't. I'll walk in and I'm like, no. Talk with the patient. Now I'm in the room. So now we're all going to talk with the patient. This is what happened this morning. She didn't want to get bathed. I try, like, there'll be two people saying, oh, she didn't let me bathe her, so I didn't bathe her. So I come in, I'm like, how come you didn't want to have a bath this morning? I was tired. You know, so these folks are no different than anybody else. They want to sleep in. They don't want to be woken up at 5 a.m. for a bath. They want to watch TV and do nothing and just relax, especially on a weekend. So we have to remember that a lot of these needs are what should be done with everybody every day. You assume the person understands you. Another thing that many people are guilty of is this person's trying to tell you something and you just go like this. Yeah. Now, the folks that get that you don't understand what they said will challenge you and say, what did I just say? And then you're stuck. So you should never just pretend that you understand what they're saying. That will only increase their frustration when they can detect that. They would rather repeat themselves. I have patients that would rather say it 10 times in their own attempt than you just nod and pretend you understand on attempt number 1. So just politely say, can you just repeat that? And I'm very direct. I say, I'm sorry, I'm not getting that. I'm not getting that last word. I'm not getting that first word. I'll be very specific to try to limit what they have to repeat. It's very important. And that's why I have that at the bottom. It's okay to say to somebody, I'm not getting that. Go ahead. So this is, again, just talking about in general that their receptive skills are intact, pretty close to the end of the disease process. It's really that they become non-intelligent. They can't make it intelligible, and they can't make the person understand what they want. And that's why we can try these other tricks. But you can use this respectful communication also when talking about end-of-life decision-making. Do they want to go to the hospital? If they don't, they can be a D&H, which is a do not hospitalize. If they don't want to be intubated, have a breathing tube put in, it's a DNI, do not intubate. If they don't want to have CPR done, it's a DNR. And these are things that have to be explained very carefully to them. What is the process? What is CPR? What happens when you do CPR to my body? It's important for them to understand, just like it is for us, whether that's something we think we're going to want. And there can be exceptions. You could say, if I become completely unresponsive and there's no hope for me, becoming responsive again, I don't want any heroic measures. But for other people, sometimes they're willing for temporary. What happens if it's just someone that has a heart attack, but they can be brought back with CPR and they're still pretty functional in their lives? Yes, they have HD, but if in that moment you're still functional and communicating and seeing family and enjoying staff and activities, then it makes sense that you would not have a DNR, because you're somebody that wants to, keep going and enjoying your life the way you are. So if we think the person can understand, at least with yes, no questions, we definitely try to have this person discuss this with us, usually with social work, speech, whoever is involved in the meeting, to try to make sure that the person does understand. Go ahead. So this is something too. Behavior, as we know, is very common with a lot of patients, not everybody. It's, that triad, the motoric, the cognitive, the behavior, these three, the points of a triangle. Sometimes people can have all of them. Some people only can have one, like just they're very behavioral. And in the very, very old days, a lot of people with behavior were misappropriately and mistakenly placed in psych institutions because they didn't understand that it was part of this whole neurological process that affects the part of the brain, eventually goes to the frontal lobe, and the frontal lobe is our filter. There's many times, I'm sure, the people on this call, you have been in a store and you have wanted to scream something obscene at the person at the register who is either too slow, or the people in front of you are, putting their items out one by one, and you've got one item and you just want to go through, and part of you wants to scream some kind of obscenity, but our frontal lobe filter keeps us from doing that. It keeps us in check. We can be thinking it and we can scream it in the car, but we don't end up saying it to the person. Now, I do scream a lot of obscenities when I'm driving and I'm alone in my car. So I don't need the filter then, because it's not affecting anybody else. But if I want to roll down my window and say it to somebody, then my filter checks in. And then I know that this is not a confrontation that I want to engage in. But a lot of these folks don't have that filter. It's breaking down. So I also reinforce to staff that you can't always take what people say personally. Sometimes things are said and they don't really mean it. They're just angry and they don't know a better way to express themselves because their communication is getting more limited. They're maybe kicking at a caregiver because they don't want to be washed at that time, but they can't say, I don't want to be washed right now. So these are sometimes things that are happening that are out of their control. They don't have that cognitive control. They don't have that filter. And so we have to try to be the bigger people and suck it up when something is said. It could be hurtful, but we try to do the best. And this is so important, I think, for spouses caring for people at home. You know, you're shocked sometimes at what your spouse will blurt out and say to you. Now, in a normal situation, I know with my husband in the past, there would be fights. Sometimes you'd say things you shouldn't, but then you would come back to the table and talk about it and you'd be okay. A lot of times these folks don't even remember what they said. To try to come back to it is difficult, but in the home, it's more personal because you're living every day with the person. So you just find a way to sort of say, you know what, that was hurtful what you said before. I understand maybe you didn't want me to wash you right now, or maybe you weren't hungry and you didn't want to eat right now. So we're just going to take a moment and calm down and then come back to it. And you know what, that's like good advice for anyone, even in a relationship, to not say something that you're going to regret at a later time. But just to remember that for these folks, they don't have that filter. So sometimes stuff gets blurted out and they can't help it and they don't mean it. Go ahead. So this is what I feel is very important for behavior management. Patience with people because they need time. Perseverance, make sure that you stick with it. You don't let things that happen and little roadblocks stop you from what you're doing to provide the best quality of life for this person. Creativity, I know there's a lot of super creative people out there. We do some creative things at Hartwick. Even when I'm just doing evaluations at the hospital of people that don't have HD, I feel that these folks are in the hospital, they're sick, they're not happy. A therapist that goes in and just reads from a book and waits for answers, and it's so impersonal. I try to go in with humor. I try to go in with, you know, knowing their name and addressing them by their name. These are things these folks appreciate because they're in the hospital and they don't want to be there. So getting creative with what you do, being consistent with that creativity, try not to vary too much, try to find something that works and then keep doing what works. Don't keep trying to change it. It's like people say, you know, if it isn't broke, don't fix it. If you find something that works, just stick with it till it doesn't work anymore and then get creative again. And then lastly, compassion. It's, again, the empathy is so important because we don't have HD. We can't put themselves in their shoes. And so we have to be careful what we say because they do understand what we're saying. And you can't say, well, you know, this is what you have, so you have to live with it. You know, that's not something that you can say to somebody with Huntington's because we have no idea what it's like living with it. And I end that part about compassion with when my second husband passed away. Initially, what upset me the most is when people would say, well, God has his reasons. And I'd be like, yeah, he's 58. I'm sure there were no good reasons. Or someone would say to me, it was his time. And then I would say again, he's 58. So people, if you're not sure what to say, even in this environment, you need to just try to be kind, say what's easiest, say what's least amount of detail, because the more detail, the more confusing for these guys anyway. So keep it simple, keep it compassionate, and it makes it easier. You think, is that my last slide? Yeah. Okay. So does anyone have any questions? No one to stop talking and listen. So that's me right now. Any questions?
No.
Okay.
All right. Excellent. Well,
That was
thank you
great,
so
and
much.
thank you.
Thank you.
Good job, Lynn.
Thank you.
Always
Yeah.
appreciated to hear you speak.
Good job.
Anytime. I enjoy
Thank
it.
you. Thank you so much.
Yeah,
You're
thank you.
welcome.
Yeah, thank you.
So I've been occupying the bathroom now for an hour, so I have to go. But thank you for having me, guys.
Oh,
Thank you.
thanks so much.
Okay, and I'll talk to you guys soon. Karen, I'll see you Tuesday.
All right, that sounds good.
Okay, thanks, guys.
Thank you.
Bye.
So at this point, I think we're going to just take a couple-minute break, and then everybody meet back at 11:10, where we'll be hearing a little bit from Leora Fox. So we're going to, again, just take a 5-minute break. We'll be back here at 11:10 to continue with the rest of our day. Thank you.
All right. Thank you. For coffee.
Corlin, you need anything from me? Up, you're on mute.
Thank you. I'm just waiting for our break to end, and then I will get started with Leora's presentation. So I'm good.
Let me know if you need anything. Everything's going great so far.
All right, excellent. Thank you.
Thank you.
A mask, like a plastic mask. Like what
So
I
we're
was
back?
wearing as a kid.
Not yet.
We are almost back.
Oops. Well, the only good thing about this is I can clean the bathrooms while I'm listening. At least I'm getting my chores done.
That is important.
It is. It is Sunday. Let's see, where do you go? How's your family? Everybody well?
Everybody is well. Thank you. Oh, and here's one of our
Yeah.
speakers joining us. There we go.
Doing well.
Yeah, hanging in, you know. Hi, Madeline. How are you?
She's on mute.
I think you're muted. Oh,
Okay, can you hear me now?
I can.
Okay,
Excellent.
okay,
All
okay.
right. So we have one presentation to do in just a minute, and then that's take about 5 minutes, and then we would love to have you share with us.
Sure, that'd be great. Thank you so much. And
Yeah,
thanks
thank
for
you
all
for
your
being
work
here.
in setting this up.
Yeah, thank you.
There's
All
Madeline.
right. So I think it looks like Stacy's still out, but I think we can get started. I'm going to welcome everybody back. Next, we're going to be hearing from Leora Fox, a research update. She is the manager of research and mission programs at HDSA. So again, I'm going to be sharing my screen, and she's going to tell us a little bit about what's been going on.
Okay, thanks again.
All right, so.
Morning, everyone. I am Leora Fox, Manager of Research and Mission Programs at HDSA, and happy to help block. And I first want to reiterate how grateful we are that you have continued to contribute your time and your resources to HDSA's mission during this very difficult time for our country and the world. And so thank you so much for being here and for participating. And I am here to talk a little bit about the state of HD research today, to give a little hope message about the science that's going on right now. So bear with me as I share my screen. All right. So it's an absolutely unprecedented time for HD science right now. There are dozens of companies, as you can see here, that are working on Huntington's disease right now. This slide is already too busy. That's not even a comprehensive list of the companies that are working on everything from drug discovery all the way through late stage clinical trials. It's very exciting, and it feels like we hear about another company every month. So we have a lot of hope in particular invested in Huntington lowering therapies that are in clinical trials right now. And these approaches aim to lower the amount of the harmful proteins that build up in the brain over the course of HD. So there are two companies right now that are testing these therapies that are called ASOs, and they're delivered into the spine. One of them is called Roche Genentech, and they're conducting a trial with about 800 participants all over the world. And we're expecting to hear the results from that trial in 2022. And this is a trial to test whether the drug can slow down the
large trial is successful, it could move towards approval by the FDA. Wave Life Sciences is also conducting 2 smaller trials to test whether their ASO drugs are safe. And if this is successful, they'll move on to testing in larger groups of people. There's also a company called Unicure that has begun a small safety trial of a Huntington lowering drug that is delivered one time via a brain surgery. And we know that recently the first 2 participants have undergone the surgery. There are also researchers and companies working on ways to deliver Huntington lowering drugs that could potentially be taken as a pill. And this, of course, is the holy grail of genetic therapy. And it sounds like science fiction, but we're actually quite likely to see a trial beginning within the next couple of years. So this is some very exciting work on Huntington lowering. And we know that COVID has not significantly impeded any of the progress of these trials. So in addition to Huntington lowering, there are ongoing trials currently that aim to treat different types of symptoms, like the movements caused by HD, changes in thinking, as well as things like inflammation in the brain. So there's clinical research approaching HD from many other angles as well. And there are also researchers all over the world in academic laboratories and biotech laboratories who are discovering new ways to potentially treat HD in the future. And some examples of approaches that scientists are excited about right now are attempts to delay the onset of HD symptoms by shrinking or slowing the expansion of the genetic code, slowing the growth of the extra CAG repeats in the gene that causes HD. There are also labs working on ways to correct the mutation with gene editing techniques. You may have heard of CRISPR. And there are others that are studying stem cells from adults with HD to better understand what's wrong in the body and brain and identify new pathways to treat. So that's a lot of stuff to digest in a short time. If you're interested in learning more about any of these things, I really recommend checking out some of HDSA's resources like HD Buzz, which explains HD research news in plain language, our blog This Week in Huntington's Disease Research, and our webinars. You can also learn more about how to participate in HD research by checking out Enroll HD. You can do a Google search for that, as well as HD Trial Finder. And you can find currently recruiting trials through HD Trial Finder and match to them. Or you can speak with an expert in the HDSA Center of Excellence. So again, I want to thank you so much for being here and have a wonderful week. You're always welcome to contact me with research questions directly, Nora Fox, lfox@hdsa.org. Have a great day, everyone.
So
Hi.
again, that was Leora Fox, and she was giving us an update on the state of research. And it's always really wonderful to hear everything that's been going on and that there really is so much hope for the future. So I'm going to let somebody else into our, there we go. Okay, and so next we have Madeline Carfmacker.
Right.
I tried.
Exactly right.
And she's a social worker, and she's going to be taking us through a guided meditation. Do I have that right?
Absolutely, you're absolutely right. Thank you again for all the setup you did of this, and this is the first time I'm doing this on Zoom, and I feel like basically I will take you through a several minute relaxation at the end of this, but I feel I want to preface it with, since COVID, I feel it's so important to do something along the line of relaxation. You hear the word like mindfulness, relaxation, meditation. If from a spiritual point of view, there's centering prayer. All of them are really basically what you're trying to do is just take time for yourself every day where you really sort of just go within and try to let go of all the million thoughts that are going through your mind and pressures and everything. And I feel like it's been proven scientifically over and over again. And like I said, especially now with the pressures of COVID, that you really can't survive or function unless you do take this self-care to yourself every day. And for all the different practices, the basic recommendation is that you just do it, you know, that you make sure you take they do recommend 2 times a day, 20 minutes for each time, that you take that amount of time for twice a day, that you're in a place where nobody's going to disturb you. You have all your devices turned off. You know that nothing's going to come and ask you to do anything. And that you just, whatever you're doing, if you're doing a guided meditation, if you're doing just a centering prayer thing where you just sort of let go of all your thoughts and go within, if you're doing sometimes yoga is more effective to them, where they're doing body movements and incorporating relaxation through that. Whatever it is, the most important thing is that you do it and that you not judge yourself. I think there's a lot of pressure in meditation that you should be, you shouldn't be thinking about anything else, and you're constantly trying to think, oh, am I thinking about a thought? Should I let it go? The bottom line is there should be no judgment in it. Just practice compassion. And what they say in all the different things is the real point of it all is to always bring yourself back, return to that place within that's at peace and has everything it needs to. That it doesn't matter how many times your mind gets distracted or you get another thought pops into your mind, that's not a problem. It's just, it gives you more opportunity to return to that place of peace and relaxation. So with that being said, if everybody wants to just get as comfortable as they can, and it's usually better if you're sitting up, feet on the ground, but if you're more comfortable lying down, that's also fine. Again, it's usually helps if you want to go ahead and close your eyes and just listen to my voice for the next few minutes as I talk you through this relaxation. So again, just get comfortable, close your eyes, and start with a really deep, slow breath in through your nose and slowly out your mouth. Just relaxing and letting go. And just sort of remind yourself that for the next few minutes, you don't have to do anything. There'll be no demands on you, nothing you have to get to. It's just your time to relax and let go. And just sort of picture all your thoughts and worries, everything you're supposed to do today. Just picture them all melting like a stick of butter onto the floor. You can pick them up later if you want to, but right now just let everything melt away as you focus on your breath. In through your nose, 1, 2, 3, and out your mouth, 1, 2, 3. Just relaxing and letting go. And again, just picturing everything else just melting away. And if a thought pops into your mind or any noise distracts you, that's okay. But as soon as you become aware of it, just gently and lovingly bring your focus back to your breath. In through your nose, 1, 2, 3, and out your mouth, 1, 2, 3. Just relaxing and letting go. Relax and let go. You might be aware of the feel of your breath on your nostrils. It may be warm, cool, and feel the air go out your mouth. Breathing in, 1, 2, 3. Breathing out, 1, 2, 3. Breathing in, I relax. Breathing out, I let go. Relaxing and letting go. And again, if you get distracted, probably a million thoughts will pop into your mind, but you don't have to hold on to them. Just let them go in one ear and out the other as you continue to relax and let go, breathing deeper and deeper. And if you want to, in addition to breathing deeper and deeper and relaxing and letting go, just sort of scan your body and just consciously just let go of all the muscles in your whole body. Just let go and relax. You can picture like a rope from the top of your head to your feet. Just watch it unravel as you loosen up the muscles in your face, down into your neck and shoulders. Just feel them loosen up and relax like a rope unraveling. Down and through your arms and your hands, down your upper back, lower back, chest and abdomen, down through your legs and out your feet. Just relax and let all the muscles in your body go loose and limp as you continue to breathe deeper and deeper, relaxing and letting go. And as all your muscles just loosen up and relax, just be aware of how you may feel very, very heavy and relaxed. And just sink into that heaviness. Be too much trouble to move, just too much trouble. Just relax and let go. All your troubles are far, far away. And all that's real is that part of you on the inside that has everything it needs and knows everything it needs to know. And just listen to that voice within yourself that knows everything and knows that every day you're getting better and better in every way and that all will be well. Just feel that inner part of you that's strong, safe, and good. And just be aware of how you're perfect in every way as you continue to relax and let go. Again, with each time that you get distracted, fine. Just say, oh, I need to return, and just let go and relax. And just enjoy that feeling of peace and relaxation. Be aware of how it feels to have all your muscles relaxed, to just be within, to be breathing deeper and deeper. All your troubles far, far away. And just be aware of that heaviness and just sink in to that heavy, relaxed feeling. Be aware of how it feels. And just know that no matter what's going on outside of you, you can always go within like you're doing now. Just relax, let go, and just know you have everything you need. And be really proud of yourself to be able to relax. Things can be all swirling around you, but you don't have to grab onto them. Just go within, relax, and enjoy. And just take the next couple of minutes to just continue to breathe deeper, deeper, relax, let go, and just listen to that voice within that knows everything. Just relax and enjoy. And again, if you get distracted, it's fine. Just bring yourself back to your breath. relaxing and letting go. And just be aware of the silence around you and how the silence is very much full of presence and everything you need, knowing that you're getting better and better every day in every way. Relax and let go. And just enjoy that feeling of peace and relaxation. Enjoy and relax. And be at peace with the silence, breathing and letting go. Relaxing and letting go. And again, just relax. And I'll let you know when it's time to come back to the present. But for now, just stay within the silence, peace, and relaxation. And as you feel ready, just sort of gradually bring your awareness back to the room you're in. Feel your body against the chair. And just very, very slowly take a really deep, slow breath. And slowly open your eyes and take in the room around you. Taking a deep breath. Be ready to finish out your day in peace and relaxation. And know that all is okay. And some people like to stretch, like stretch your neck or stretch your arms out. Good. Just slowly enter back in to the present. Knowing that at any time you can go within to that place of peace and relaxation. And going forward, I just want everybody to know that the internet's just full of all kinds of relaxation apps. You know, sometimes people get more relaxed with music, other people with just sounds of like the ocean and mountain. Sometimes people, you know, don't like the outside and just like to go within themselves. But there's all kinds of stuff free that's available to guide you in that. And again, I can't stress enough that, you know, to avoid testing yourself or judging yourself or saying that, you know, you've got to do it one way. Because really, the biggest thing is that you just do it. And by that, I mean that you take 20 minutes, like set a timer twice a day where you're just by yourself in a place where you're not going to be interrupted, where you just go within and do whatever, you know, works for you. And also for anybody that's spiritually inclined, there's all kinds of, again, information on the internet, books about centering prayer, which is, you know, basically the same thing, but with a component of God and spirituality. thank you all so much, and hope this was okay and that you could hear me again. I'm doing it on my phone. I hope it worked. Okay.
It was
Thank
wonderful.
you.
Thank you
That
so
was
much.
great.
Madeline.
Thank
We
you.
really appreciate
No
your
problem.
time.
No problem. Thanks
I
a
feel
lot.
honored.
Good luck, everybody. Stay calm.
Thank you.
If you
Thank you,
can.
Madeline.
Bye-bye.
Appreciate it. Thank
Bye-bye.
you.
Bye-bye.
All right. Well, hopefully everybody's feeling very relaxed right now.
Mm.
Now I feel more relaxed than I did before. So our next speaker is going to be Shlomo Cohen, and he is the Director of Operations at Elder Guide. And so he's going to be talking to us a little bit about planning for our future. So are you there, Shlomo? There we go.
Do you hear me?
I can hear you. Yep.
Okay, great. Do you see me?
I do not see you.
Okay. Okay, 1 second.
Yeah, take your time. There we go. All right. Excellent. Thank you so much for being here. We really appreciate it.
Sure. Okay, thank you. Thank you for having me. And I'm definitely feeling pretty relaxed right now.
Right.
That was great. So just making sure everyone sees me.
Yes.
Yeah.
Okay, let me just get my screen on that. Sorry about that. All right, you let me know if you don't see me, right?
Yeah,
Okay, we're good?
we're good.
Okay, thank you. So my name is Shlomo Cohen, and I'm the Director of Operations at Elder Guide. We're a Medicaid application company, and what we do is we assist residents, families, with the New Jersey Medicaid application process. And today I just want to talk a little bit about what the application process entails, and what could we do to plan for our future, and to try to avoid all the different pitfalls and the aggravation that comes up with the application process. Again, thank you so much for hosting me, and really thank everyone for joining. I hope everyone is staying safe. As they say, test negative and stay positive. Okay, so I'm gonna break it into three different parts. Number one is the 5-year Medicaid look back I want to talk about, which is Medicaid has a 5-year look back, and when you're applying, they look back at your finances going back 5 years from the day that you apply. So that's the first thing I wanted. Number one. Number two, we'll talk about the resources, amounts, and income limits in being eligible for Medicaid. And number three will be the common Medicaid issues, pitfalls, and what could we do to avoid them. So number one, as I said, we'll talk about the Medicaid 5-year look back. So when you apply for Medicaid, and we're talking about over here is for either for long-term care in New Jersey, or to be able to get Medicaid assistance in the community at home, which would entail a nurse coming out. So that's what we're talking about over here. So when it comes to that, there's, like we said, a 5-year look back. So what that means is that Medicaid will go, when you apply, Medicaid is going to be looking from the date, well, actually for the month that you apply, they'll be looking back 5 years at all your financials, and they'll be questioning everything that happened. So it's extremely important. We never know when exactly we're going to need Medicaid, or when we when the time will come. But as we're as we're getting closer to, we think that there might be, obviously we can never know exactly, but that's why it's always good to plan as much as you could prior. But what's extremely important to keep in mind is that, like I said, they'll always be looking at 5 years prior. So you can never stress enough the importance of not gifting out money, making sure that money is not given out to relatives, to children, or whoever it is. You want to be very careful about that. And the reason is that Medicaid will always consider that. They'll always issue a penalty for that. Now, without getting involved in what the penalty, how that works exactly, but bottom line, we want to try to avoid that. If you do get a penalty, they have a divisor, $353 and a few cents a day. That's the, current's always changing. So number one is we want to always avoid gifting out money, within the 5-year look back period. It's very important to note that the Medicaid guidelines differs from the IRS. So although the IRS always allows gifting in regards to taxing and to taxes, and people always come to me and they'll be like, oh, but what do you mean the IRS and we're allowed to gift? So it's very important to differentiate between the IRS and Medicaid. Whereas the IRS will give, I'm not a tax advisor, but I think it's about $14,000 a year you're allowed to give to somebody, and for tax purposes. When it comes to Medicaid, anything that you gift, they could potentially penalize for. So again, never confuse IRS and Medicaid, even though we're both they're both government, both government, but it's totally different regulations. So you never want to confuse the two. Of course, a lot of times people have caregivers, or people that are assisting their loved ones or themselves at home or wherever it is. So, and of course, what's the, it makes sense. You got to pay for a caregiver, and of course you should go about doing that. What the problem is that Medicaid will always question, like I said, they're always questioning 5 years back. They're always questioning all types of transactions. So if you're giving cash to a caregiver or even checks, you want to keep very, very good records, ledgers. Of course, the optimal would be if it goes through an agency where there's records and the agency has invoices and you could back it up with checks. Of course, that's optimal, but that's not always the case. And people have other reasons why they're not using an agency, or they're using, someone they know. So it's extremely, extremely important to always keep good records. So, you might have a caregiver that wants cash. Obviously, the best thing is if you're working with checks and there's ways to verify where the monies went. But, we have times where, people would give cash to a caregiver. Number one, most important thing is to always make sure you're keeping good records of where everything went. Keep, times of how much they worked. This way you always have, like I said, good documentation, verification. Again, I'm sorry for not saying, but if anyone has any questions in the middle, if that's okay with the hosts, if anyone wants to, ask me in the middle, or we could wait till the end, whatever's okay with everybody. I'm good either way.
And also, if anybody wants to put anything in the chat box anonymously, I can also ask Mr. Cohen for his answer. Thank you.
Awesome. Yeah, sorry I didn't say that in the beginning. So we're talking about keeping good records for caregivers. Extremely, extremely important. We have all the time where people come to us, and as we're putting things together, then we realize there was a lot of money that was given out to caregivers, and we run into so many problems. So where it was cash, they can keep good records. And another thing is that the caregivers a lot of times will, they didn't, again, I'm not their tax consultant, but they don't want to report the money to the IRS, and that's why, they don't want to testify. So I always say, you don't have to worry about that. The Medicaid, is not speaking to the IRS. They don't work in tandem. So if there's a caregiver that was involved, we always want to be able not scare them off and have them give us as much information as possible, so we can present it to the Board of Social Services. So that's in regards to the 5-year look back. Just again, quickly, keep as meticulous as possible, your records of any money that was given out during that time. Number two, always be careful not to gift, and really to keep as the best records as possible, because with Medicaid you are guilty until proven innocent. So unfortunately, but that's you can never be careful enough when it comes to the Medicaid 5-year look back. Okay, so that's the first thing I wanted to talk about. Any questions, any insights, any comments?
I just wanted to comment on the caregivers. I know I'm a social worker, and I often tell people to be careful about paying a private caregiver, because somebody had once told me that there could be an issue with the 5-year look back, but it had never been explained to me like that. So that was very helpful. And I appreciate having that information. So it's not that they can't pay one, it's that they should be very careful about documenting how they pay one and where that money went.
Yeah, absolutely. Like I wouldn't tell someone, no, you can't use, a caregiver. And it just, as long as you keep good records of it, and you'll be able to document everything, you should be fine. Of course, it's always best to go through an agency, something like that, but not everyone always has that opportunity. And I would never want to tell somebody, they can't use the caregiver that they think will be best for their loved one. But always keep in mind that, try to keep the best records possible. And it's all about the documentation, So if you could have good documentation where the money's went and you could prove it, then you're fine.
Thank you.
Sure, thanks. That was a great point. Okay, the next part two is resources and income. So when it comes to Medicaid, there's a resource limit and there's a income limit. Now, number one is, when it comes to resources, people get very, very scared, and they're hearing from this one and they're hearing from that one, different things, and people get very frightened. They might lose their house, things like that. And rightfully so. I wouldn't want to hear that I'm going to lose my house if I apply for Medicaid. So I always say don't always believe everything you hear in the street. Don't believe, speak to someone who knows the process, knows what it entails, and they'll be able to give you, the best information. Even if they don't know the answer, they can look into it. But don't always believe everything you hear. It's horror stories, and people really don't always know exactly the rules, and it really kind of frightens people. So when it comes to a house, you won't lose your house. If, say, someone is going to a nursing home, long-term care. If they're going to be staying in a nursing home, the nursing home makes them, as part of being, eligible for Medicaid, you'll have to list your house. Which, if you're going to be staying long-term in a facility, it kind of makes sense that they're going to make you list your house. But if you have a spouse in the community, she'll be able to stay in that house. So really, never get scared off from that. If you have a spouse in the community, she or he will always be able to keep that house. Number two, if someone is applying for Medicaid to be able to get services in their home, of course, you'll be able to keep your house. So really no worries on that end. Where resources come in is that depending on whether there's a spouse, there are different rules on how much you could keep in resources. Now, the logic behind that is that Medicaid says that, if you do have resources, then, those resources should go towards your care before Medicaid kicks in. Now, I'm just going to give a little quickly, the guidelines. But if you're going into a facility and you need Medicaid for long-term care, so Medicaid allows you to keep $2,000. I know, doesn't sound too much. Unfortunately, we don't make the rules, but that's the Medicaid rule. So you're able to keep $2,000 in assets and be eligible for Medicaid. However, if you do have a spouse and who is staying in the community, it's a whole different ballgame. So people get very scared where my spouse is my loved one is going to a facility, I'm going to be stuck at home. Well, how am I going to be able to keep keep afloat, keep alive. So the answer is Medicaid allows you to keep a significant amount of money. And just a quick, those numbers is that if a spouse could always keep half of their assets. So say you have $100,000 in savings, Medicaid allows you to keep, allows the community spouse to keep $50,000, the spouse who's applying for Medicaid $2,000, but the remainder from, basically so up to $52,000 between both of them, you got to spend down to $48,000 to get eligible for Medicaid. So you can always keep half the assets still. It's not including the house you keep anyways, but in, let's say, liquid assets, you're able to keep half. Now, there is a maximum on that. The most you'll be able to keep is $128,000. So say you have $256,000, you'd have to spend down to $128,000. Say you have more than $256,000, you have $300,000, you wouldn't be able to keep $150,000. You go down to the $128,000. Again, that's the maximum that you're able to keep. There's also a minimum that with a spouse in the community, let's say there's always a minimum of $25,728,000 they're always able to keep also. So let's say in savings together you have $25,000, you could keep all that. Let's say you have $40,000, you don't have to spend down to $20,000, you could keep up to $25,000 as a community spouse. So again, it's just to keep in mind that you always could keep half. There is a maximum of how much you keep, even in that half, in the half that you could keep. But at the same time, there's always a minimum as well that you could keep as well. So that's in regards to resources. People also get, people also question how much in income, and we get calls all the time that people say, oh, we make too much money, we have too much income, and income I'm referring to, Social Security, pension, that's what we consider income. And people say, well, we get an income, we were a teacher, or let's say, work for the government where we have large pensions. And I was told that you're not able to keep, you're not eligible for Medicaid if you have a large income. Again, don't believe everything you hear. That's not true at all. There's never an income amount that will make you ineligible for Medicaid. Medicaid did put in a rule in 2015 where if you do have a certain amount of income, things change and we have to open certain accounts. It's called a qualified income trust. Some people most commonly known as a QIT. That's something which it just kind of made another step in the process, but you'd still be eligible for Medicaid. Right now, it changes every year, but right now the income amount is $2,349.60. So if you make income, whether Social Security or pension, they look at it together, of over $2,349.60, you'll need what's called a qualified income trust. We're not going to get into that right now, but just an idea of what that people shouldn't be scared off from the fact that that they have a large income. You could still be, but will be eligible for Medicaid. It's just different rules that are involved once you have that large income. So again, just on this part 2, we talked about the resources and income. People should never get scared off that because they have a house, they won't be eligible for Medicaid. People shouldn't think they have a certain amount of resources, they won't be eligible for Medicaid. You'll always be eligible for Medicaid. It's just a question of how much you have to spend down or how much you don't have to. And again, the same in regards to income is along the same lines. No matter how much income you have, you could always be eligible for Medicaid. It's just a question of how things have to be done. I hope I was clear. There is a lot more on that, on the income resource part, but that's just an overview of the resource income limits applying for Medicaid. If anyone has any questions, comments on that segment, or if they thought of something about on the first segment, please feel free.
That's been very helpful. Thank you.
Okay, sure. Happy. Thank you. Okay. Part 3. So part 3, I just want to talk about, the issues with applying for Medicaid, pitfalls that could come up, and what could be done to avoid that. So some of you might know and some of you might have heard, but when it comes to Medicaid, people get very scared. And to be honest, there is what to be scared about. And the reason is because, it's a process, and it's not like some other government programs where it's pretty easy. You just apply, and either you're eligible or you're not eligible, depending on your income and depending on your, maybe your assets, whatever the determining factors are. However, when it comes to applying for long-term care or assistance with medical assistance, it's a much larger, a much bigger and harder process. And the reason for that is because Medicaid has they have the 5-year look back. And what they're doing is they're looking back at all your finances, all your transactions that happened over the past 5 years. So there's two parts of it. There's the financial part of it, and then there's the documentation. So in regards to documentation, they ask for all types of, I'll just give a quick list, but proof of age, marriage, divorce documentation, Social Security cards, Medicare cards, things like that. So, those are all things which you might not have, but it's something which is, you're always able to, dig up and get one way or another. The main problem is the financial part of it, where they have the 5-year look back. So when people get scared is because, unfortunately, the Medicaid offices and what's really the Board of Social Services are extremely, extremely slow. And whatever the reason for that is that it's just the process is so enormous, and there's so much information that they're going through. Remember, it's 5 years of finances on every single account, stock, life insurance, bank account, brokerage account, and they have to comb through all that. So the process takes so long, coupled with the fact that, it's going through the government bureaucracy. So you're dealing with, short-staffed agencies, and it's just, you could have scenarios where you apply 8 months to 12 months later, and you still haven't been given a decision. So, and that's where it comes from, that people get very scared about applying for Medicaid. So the answer to that is that there's no really simple solution. But the best thing that someone could do when they're applying for Medicaid is to have everything that they'll need prior. So, and that's really what our company was founded for and what we do. But, without getting involved in, of course, exactly how we do it, but the idea is that when you're applying for Medicaid, you want to have everything that you'll need prior to applying. So if Medicaid is going to want 5 years of bank statements, you don't want to apply, and then when they get back to you, then submit your 5 years of bank statements. Or even if you do submit originally your 5 years of bank statements, but you don't want them to come back and say, okay, but we went through your statements and we see there's checks. Could you please get us check images? Or we see that there's a dividend that you're getting from a stock. Well, now please get us information on that stock. When things are done that way, so what's happening is that you applied. They're not looking at it for 2 to 3 months till they look at it. Once they look at your case, well, then they're sending you back a letter with information that's needed. They give you 10 days to respond to them. So, you're already starting 3 months, behind. Then they want information. If you don't get it to them in time, they can potentially deny your case. So the goal always is to have everything that Medicaid will ask down the line. You want to have it prepared prior. So when they're looking at your case, you have to look at it as you have your one shot. You have your one shot to present everything to them. If everything is there for them, it's a quick decision. Everything's there, and they'll decide whether they want to approve you, whether you're approved or not. If not, you don't have all your information. Well, then it starts the back and forth. You give them some information. They come back to you asking for more information. Basically, a ping pong game of never-ending ping pong game of more information. You send them one, they come back to you. You come back, send to them. So again, the most important thing is to have all your information, documentation, as much as possible prior to applying. And that's really what our company does. The The name of our company is Elder Guide. We're a Medicaid application company, and all we do is assist families with getting all the information that's needed. And we make sure when we apply, we're basically spoon feeding the information to the caseworkers, basically doing their job for them. So when they get it, everything is comprehensive, organized, and well documented for them. So again, on this segment, the number one thing to keep in mind is that when you're applying for Medicaid, have all your information that will be needed, have it prior, and have send in as much documentation as possible the first time around. If anyone had any questions at any time, of course now, but come up with things down the line. We're always available for questions. You can meet us, find us on our website, www.elderguide.net. Feel free to email, and you can ask questions from there. You can always email us at info@elderguide.net. And I give you my number. It's 908-212-1691, 908-212-1691. We're always here to answer any questions. People are looking to apply for Medicaid. We're always available.
Excellent, thank you. I do have one question about the timing of applying. If you think somebody's going to need long-term care, at what point should you start the application process?
So that's a great question. Excellent question. So you never want to apply too early, because like we said, Medicaid only allows you to have $2,000 as an individual, or like we said, if there's a spouse, things are a little different, or a lot different. There's a lot more money you could keep. So, you don't want to apply when you have $50,000, because they get your application, they say, okay, there's too much money, let's, what are you applying for? You still got to spend down your money to be eligible for Medicaid. So I would, we would try to say within a month or two before you want to, start applying. So let's say you have $10,000 to $20,000. If you're in a long-term care, you're paying about $11,000 a month. So within a month or two, you'll be eligible for Medicaid. So by the time they're looking at your application, you're pretty much there. So you want to apply about a month or two prior. However, you definitely want to, start thinking about applying prior. And the reason for that is this way, we always tell people, when you have, less than $100,000, it's not too early to apply, not to apply, but to start talking to a Medicaid advisor, talking to an application company, because the more time we have to start gathering information and to put these together is the more documentation we could submit when we actually apply. So we don't apply till about a month or two prior, but we want to make sure when we're applying, we have all the documentation needed when we submit our application.
Okay, thank you. That's really helpful. That actually just also, I had one other question about Medicaid pending. Do you find that a lot of long-term care facilities are willing to take patients if their Medicaid is pending?
So, another great question. So, of course, that varies by the facility, but so and it depends. And the argument for taking a Medicaid pending is because a facility says, okay, once the Medicaid goes through, we'll get paid, and they'll have a payer source in the facility. But a lot of facilities, they don't want to take a Medicaid pending because they don't know what the status of the Medicaid is. So it all depends, and that's why a lot of facilities want to know that before you come in, if a family applied on their own, well, could you show us documentation that you applied? Could you show us what was submitted? And the reason for that is because if you don't know what was going on, so then you don't know if this Medicaid isn't going to get approved. You don't know if there was gifting that went on. Of course, in a optimal situation, everyone would like to take everybody, but unfortunately, the Medicaid offices are so strict, and you really never know with them what's going to be. So that's why some facilities don't want to take Medicaid pendings. However, if they know that it was done through a company that they have a relationship with, and they could trust, and they tell them that, yeah, we took on this application, we know exactly what's going on, they're more, they'd be more open to taking it. A lot of times they'll ask the family, well, could you show us what was submitted? We want to see your bank statements for the last 5 years, which sometimes families might find a little bit, intrusive, like, what are you asking us? But at the end of the day, Medicaid has the rules, and if it's not going to get approved, Medicaid wants to know that, the facility wants to know that prior.
Yeah, that makes sense. Yeah, thank you. I appreciate that. All right. Are there any other questions today? I really appreciate you joining us today. It was really helpful. I know every time that I learn a little bit more about Medicaid, it really helps me in what I do. And it is so complicated. So I appreciate that you're out there helping families. And so really that concludes our education day today. We want to thank everybody for joining us for our celebration of hope and planning for the future. And there is a lot of really wonderful stuff happening out in the HD community. And so anytime we can all get together and talk about what's going on, I think I find it really helpful, and I hope that everybody else does too. So thank you again for your time today, everybody. And I hope that everybody enjoys the rest of their day.
Thank you, Corlin.
All right. Thank you.
You're right.
Thank you.
Take care,
Have a great day, everybody.
Bye. How do I end myself?